Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Shay Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today, I'm pleased to announce that we have Dr. Ahmad Elashery joining us. Dr. Elashery is originally from Cairo, Egypt, and a graduate of Ain Shams University Medical School, where he performed many healthcare-related jobs, including military unit and critical care residency. He completed internal medicine residency and was chief resident at the Greater Baltimore Medical Center. He completed a cardiovascular fellowship at Danbury Hospital in Connecticut, where he was also chief fellow. Dr. Elashery then went on and pursued cardiac imaging fellowship at the University of Kentucky, where he achieved level 3 training in cardiac MRI and cardiac CT. Dr. Elashery recently started the Hypertrophic Cardiomyopathy Clinic here in Charleston in December 2022, which continues to grow tremendously. In September of 2023, he was named Program Director for the CAMC Cardiovascular Disease Fellowship Program, and he continues to serve in that role. Thank you, Dr. Elashery, for joining us today.
Thank you. This is a really great introduction that I may not deserve all of it, but thank you. Thank you for having me.
I've always heard that you're West Virginia's favorite cardiologist. Is that true?
If they say so. I'm kidding. I would say there is, so cardiology is a service that we all provide. It's tremendous. There is tremendous need for cardiology in West Virginia. Like family medicine doctors, primary care physicians, like we really need a lot of more doctors, more smart minds, and more hardworking individuals.
Well, we're so thankful to have you serving in that role, and that's just a beautiful way to kind of look at that. When you're not reading echoes and you're not doing heart caths, like, what does Dr. Elashery do for fun?
So let me tell you a little bit about what I do, because I don't do cath. I stay away from cath as much as
Absolutely.
possible.
Yeah.
I tell people I have allergy to the cath lab. So I do.
Me too.
I do all non-invasive work for cardiology. So I see patients in the clinic. I see patients on the floor. I cover ICU every now and then. I read all imaging modalities here, like stress testing, echocardiography. I perform TEE, which is transesophageal echocardiography. I read cardiac MRI, and I read cardiac CT. And we have other roles as well, like for being the program director for the fellowship, like educational role with conferences, etc. People ask me what percentage of the time you do what, so I can't tell you, because in one single day I can do 3 or 4 of these, and another day I can just do one of these. So it's, but I enjoy what I do, and I do them all.
Absolutely. So you mentioned the non-invasive testing. How much have you seen that change, like, the practice of cardiology as a whole here in Charleston?
So this is an excellent question, actually. We have, I can tell you numbers. So when I started here in summer of 2019, I started the cardiac MRI program. So before that, they used to do 20 to 40 scans per year. And cardiac MRI, as you know, it's sophisticated. It needs like a really trained techs, like post-processing tools, like you need the scanners that are equipped to do so, and you need a patient population that will benefit from it, and you need physicians who understands how to interpret them. Within a year, we performed, like since I started, we performed more than 250 scans. After, like, now this is the 5th or 6th year going, we perform more than 550 scans per year. And I don't want you to just focus on the numbers. Being higher numbers are always good, but it impacted many people's lives. It solved the puzzle in many situations, and this continues to grow. The same for cardiac CT. We have been doing much more now cardiac CTs than before. We have been detecting more plaques now than before. We have detecting more significant disease now than before. We have been doing more structural work, which means like we put valves through the groin rather than through open heart surgery. So this includes many imaging support with CT, MRI, TEs, etc. So I think overall, to answer your question simply, we have been progressed significantly on the last 5-6 years since I came here, not just because of me or because of another individual. The whole environment has changed. The administration are more interested in more innovations, and the role of cardiac imaging now has been significantly better than it was 10, 15, 20 years ago.
Absolutely. Thank you so much for sharing all that. It seems like as a whole, the growth of the cardiac MRI and the cardiac imaging, we've been able to start a Hypertrophic Cardiomyopathy Clinic. Can you talk a little bit about that and kind of your role in that?
So when I started here in summer of 2019, I noticed that the numbers of HCM patients are slightly more than what I used to see in my previous training. And then I realized, because I am an imager, so people send these to me, so to look at them closely, to do either TE for them, to do an MRI for them, etc. So HCM has guidelines that are updated every probably 10 years now, that tells us what to do, and they dedicate hypertrophic cardiomyopathy centers, and there is centers of excellence. So this patient population needs a little bit slight different attention than others, and the group that we have here, including myself, and CT surgeon and a structural cardiologist and an electrophysiologist and a nurse coordinator that helps coordinate the care with all of these. So since I started, we actually have probably close to 150 patients now with HCM. With, I can't tell you specific, but probably 15% of them ended up with surgical myectomy, which is the most definitive treatment. Probably 1 to 2% went for alcohol septal ablation. And probably 15-20% of them went for mavacamten, which is a medication that would decrease the obstruction in the LVOT. So I think it has been a need, HCM clinic or subspecialty clinic in this area. You just don't know how much it's needed till you actually open it. So I think it has been growing well, and people are recognizing it more and more, and I think we're helping the population, which is the most important thing.
Absolutely. Thank you so much, Dr. Elashery, just for walking us through your role here at Vandalia Health. If it's okay with you, we'll just kind of jump into our first patient case scenario.
Of course.
So we're going to present a case recently encountered in the hospital service. So Ms. Green is a 72-year-old female with a history of hypertension, type 2 diabetes, and obesity. She presents complaining of increased shortness of breath over the past 3 weeks. She reports difficulty climbing stairs in her home and waking up at night gasping for air, relieved only by sitting upright. Her weight has increased by around 8 pounds over the past month, despite no changes in her diet. Her medications consist of lisinopril 20 milligrams daily, metformin 500 milligrams BID, aspirin 81 milligrams, and ibuprofen PRN for joint pain. Social history reveals that she was a former smoker with a 15-pack year history who quit 20 years ago. She consumes occasional wine and lives with her husband. Family history is positive for a mother with coronary artery disease and father with type 2 diabetes. Physical exam reveals blood pressure 145/85, heart rate 92, respiratory rate 20, and 92% oxygen saturation on room air. Physical exam reveals patient is mildly dyspneic at rest. JVD is noted at 45 degrees. She has an S3 gallop on auscultation. Peripheral edema present up to the midcalf bilaterally. Lung reveals bibasilar crackles on lung auscultation. No wheezes noted. Her abdomen is soft, mild. Hepatomegaly is also noted. In terms of labs, she has a BNP which is elevated to 450, as well as an echocardiogram which reveals an ejection fraction of 35% with left ventricular dilation. BNP is significant for mild hyponatremia at 133 and an acute kidney injury with a serum creatinine of 1.4. Her baseline is 1.1. So Dr. Elashery, you get this patient, whether she is in your office or in the hospital, just from a cardiology perspective, how do you think about heart failure and diagnosis?
So this is classic case of heart failure, right? So you don't need any more. Actually, the first paragraph was good enough to diagnose heart failure. And this is actually very important for young doctors and mid-career doctors like myself to recognize that heart failure is not diagnosis of an echocardiography. Heart failure is not a diagnosis of just a lab value. It's not a diagnosis of cath. It's actually a clinical diagnosis. So let's keep things in perspective and go back to the basics. If clinically you have a patient with all 4 risk factors, age is a risk factor, right? She's 72. She is hypertensive, which is another risk factor for heart failure. She is diabetic and she's obese. All of these 4 are risk factors for heart failure. She comes in with shortness of breath and weight gain, again, like signs, symptoms of heart failure, and then signs-wise, like with JVD, S3, etc., etc. So this is all screams heart failure. Majority of the time now, when you see these patients, either somebody already labeled them as heart failure or they're treating them for something different. Majority of the time, because heart failure is very common in our area, we know already that we are leading the nation in coronary artery disease, unfortunately. So heart failure comes with this. I would say still sometimes we depend on our imaging modalities to identify or risk categorize patients a little bit more, which is okay, but I'd say if there is one thing that you get out of this, so just focus on the clinical vignette, focus on the clinical scenario. This will lead you to be better diagnostician and have a better treatment plan compared to waiting for further information about echo, BNP, etc. I don't think anybody would doubt that this patient has heart failure. And I'd say we should just jump into risk factor modifications, treatment, etc.
Absolutely. So when we're talking about like treatment for a patient who comes in volume overloaded, what's your first thought in terms of like management for her in terms of diuresis?
So patients has 8 pounds weight gain over a month, right? So does this mean that she's having only symptoms for a month? No, probably she has longer than this, but she just noticed it a month ago. And she's good in having a scale at home, I assume, and she's weighing herself. So I can tell just not looking at her, but just hearing your story, is this lady has like a little bit of more knowledge and self-recognition about things that are going through her mind. First thing is to tell her what's going on, right? So this is a new diagnosis for her. Many people, when they hear the word failure, they would go into depression. Oh, I'm failing, my heart is failing, so I'm going to die soon. But sometimes we use terms as volume overload or your heart pumping capacity is a little bit lower than it's supposed to, so to break the news a little bit gradually. So educating the patient is number one. Number two is tell her the treatment plan, short term and long term, because you can start by giving her, like if she came in your clinic, you can, and she's not like huffing and puffing and she can complete one sentence without catching her breath, you can start like an oral diuretic, do more, it seems like you did some labs, but complete the labs, like make sure that she's not anemic, make sure that her magnesium, calcium, everything, potassium are okay. And you can see her soon, within like few days to a week, and either in our heart failure clinic, or if you are a primary care physician or a family practitioner that can have access, like she can have access to you within few days or a week, that would be ideal. If she's too sick, or if she is doesn't have good care at home, it's better to admit these patients with new heart failure to the hospital, because she may need a little bit more work and more routine labs than she can get at home. Ideally, I would start with diuresis. There is no guidelines about like what exactly the diuresis that you should use. If she's Lasix naive, you can, and depends on her weight, you can start something like Lasix 20 IV, and then see how she responds to this, and then repeat intravenously in the hospital. I'd say goal weight loss is sometimes something that I tell people to do based on her weight. So if she is above like a regular size woman, above like 60 or 70 kilos, I'd say probably 1 to 2 liters per day. And continue to watch her electrolytes, continue to watch her response clinically, and continue to watch her creatinine. And then while you are doing this, we need, like, this is the acute management, right? So the background management, make sure she does not have pneumonia, she doesn't have any reversible cause of this, anemia, pneumonia, sepsis, acid-base disturbance, medication-induced acute coronary syndromes, etc. And if you don't have any of these, so now it's becoming like, once she start to go a little bit better with volume overload, you start to introduce other medications that are heart failure, like one of the 4 pillars, slowly, one by one, and then up titrate, and then search for the cause, right? So the big thing is, what triggered this woman to have heart failure? Yes, she has risk factors. Is it just natural progression? Or does she have an acute event that led to this? The major thing that we think of, low EF, woman in her age with her comorbidities, is ischemia, right?
Absolutely.
So now you would think about, like, how would you evaluate for that?
For decades, we have performed the most complex heart and vascular procedures using groundbreaking technology and minimally invasive techniques with a team of more than 60 specialists. Don't trust your heart to just any hospital. CAMC is the region's #1 heart and vascular center for a reason.
Stay connected with Vandalia Health for all the latest updates by liking us on Facebook and following us on Instagram and X.
When you're not feeling well, call 24/7 Care to talk with a doctor, physician assistant, or nurse practitioner by phone or video anytime, day or night, for non-emergency health problems like fever, cough, skin rashes, and more. Skip the trip and get better faster with 24/7 Care.
Talked about just even education the patient from a primary care perspective. That is huge for us, just to be able to kind of describe to them what heart failure is, and then you go through the diagnosis and management. You talked about how if she's Lasix naive, we could do 20 IV versus something PO if she has good care at home. So really looking at that patient holistically. You briefly mentioned something about the 4 pillars in regards to heart failure management. Where do you really start with that? And can you kind of explain what the 4 pillars are for our audience?
Yeah, so the 4 pillars that we have, and this is guidelines for probably more over 20 years now that are promoting these 4 medications. Beta blockers, right? And beta blockers are only 3 of them, not any beta blocker: Toprol, XL, Carvedilol, and Bisoprolol. So these are the 3 that are proven to help heart failure with reduced ejection fraction patients and had mortality benefit, right? So that's the 4 pillars. All of them have mortality benefits. They have to start as soon as possible, and combining them versus like going up in the dose, there is no science, much science, but it's more of an art, I would say. So metoprolol, or beta blocker. The next one is an ARNI. And this is the main category as Entresto. The only one in this category is Entresto. It's an expensive drug. It's probably approved, FDA approved now, probably over 10, 11 years now. And we have very strong data about it. It's a diuretic and a neprilysin inhibitor, which helps in both ways to help the heart. The third one is spironolactone. All right, spironolactones or aldactones are one of the big ones that we're using now, and they have been around the market for much longer than even Entresto or ACE or ARB. So just to go back about ARNIs, so if ARNI cannot be tolerated or is too expensive for the patient, ACE or ARB still the way to go. So these 2. The fourth one is SGLT2 inhibitors, which are again, FDA approved probably for heart failure within the last like 5 to 7 years, if I remember correctly. They are once-a-day medicines. They are described for diabetics, but they found to be very helpful in heart failure with reduced ejection fraction. These are the 4 pillars that we're talking about. There are other medications actually that we can do. They are not part of the 4 pillars, but they found to be helpful. And something like Corlinor, right, that lowers the heart rate. There are other medications that are not necessarily used that often, but it's also have benefit, like Imdur and hydralazine, decrease, like in patients who don't tolerate or have CKD or something, don't tolerate ACE or ARB or ARNIs. Okay, we can put patients on them. These are the medications that everybody with heart failure with reduced ejection fraction should entertain, and physicians should continue to up-titrate to the maximum tolerated doses. And yeah, I'm going to stop here if you have any questions.
No, that's very good, because you touched base on the 4 pillars and kind of describe what they were for us. Do you have a specific pillar that you start with first and then start adding on, or is this kind of cardiologist dependent, or can you speak more a little bit about that?
So there is no clear science or trials that did this. I remember there was a recent heart failure study that looked at up titration, all of them, like starting all small doses in the hospital versus like a couple of them like high doses. And we know that the earlier the better, starting like all of them, the earlier the better than waiting, even in the hospital. Within the first 24 or 48 hours is better. Doses-wise that were studied, I can give you an example. So the average metoprolol dose that was studied to show mortality, or that showed mortality benefit, is close to 260 milligrams.
Oh, wow, yeah.
So this is, we're talking about 200 milligram BID, right?
Not
so
what my patients were on.
Exactly. Now we're using baby doses like 12 and a half BID. Or 12 and a half once a day to start in some patients. So I'd say it's more of an art rather than like science.
Absolutely.
If your patient has a heart rate of like 55 beats per minute, right? Like senior man with like a sinus node dysfunction, I wouldn't start beta blocker.
Absolutely.
I would start something as like ARNI or a small dose of ARB to see if he would tolerate it. And so heart rate, blood pressure, body habitus, kidney disease are the main 4 factors that you may decide. So heart rate, blood pressure, body habitus, and kidney function. These are the main ones that would make you decide which pillar would I start first and how would I up-titrate. Metoprolol is our loved one, so all cardiologists like it. We have tons of experience with it. Probably if you looked at any cohort, probably 80% to 90% of the patients will be on metoprolol. So that's the go-to almost always. And the next would be ARNI, if possible. This is how I do it. Some other people do aldactone first before ARNI. Depends on the potassium and depends on the kidney function. And SGLT2 inhibitors now are very easy to start as well, very well tolerated, doesn't affect blood pressure that much. It does, but not that much. And it helps people lose weight and control their diabetes. So it's our...
you answered my next question.
Yeah.
I was going to say, let's suppose this lady had a hemoglobin A1C of 7.2. SGLT2 would be very beneficial for her. You would get the GDMT piece, and then you would also get some glycemic control with that as well. You mentioned earlier talking, this is something that we're really big on, talking about risk factor modification. How can we as primary care physicians kind of help facilitate that and kind of work together with our cardiologist?
So you guys
colleagues?
are the best in prevention, right? So we depend on you heavily on prevention because you are it. Like you will see the patient. Probably this 72 years old lady was actually your patient or some like a primary care physician patient like 50 years ago. Yeah. Right. So the risk factor modification 50 years ago or 30 years ago or 20 years ago would have helped her trajectory significantly. Like minor things that you do now in your you're much younger, but in your 20s or 30s will help you tremendously in your 50s and 60s. Right. So prevention is the key. And I can talk about like every single one of them for her. Like, by example, her age, right? Age is non-modifiable risk factor, so there is nothing to do. You can reverse your age to,
not yet, at least.
theoretically, but not practically, right?
Yeah.
So being a female, female actually is by itself, postmenopausal females carries a risk for coronary artery disease because her protection from hormones are not there anymore. So that's when I tell most of the women in your postmenopausal time, or when it starts, that's when you should be a little bit more cognizant about your health habits. If you are eating unhealthy, or if you're not doing exercise, or if your blood pressure is not well controlled, or if you are having bad days with the sugars, like you eat too much. So that's when you should be a little bit more careful, because now you don't have the protection that God gave you anymore. You still have protection, but not as much by hormones. For men, by example, I'd say starting from 40 and above, their risk factors start to change. So their basal metabolic rate changes, their lipid disposition in their arteries starts, etc. So that's when their risk factor increases. Women probably, I'd say, close to 50 years of age. Hypertension is a great one. So we have, and you guys do a lot of work, great work with this. So there are recent guidelines suggest that lowering the blood pressure less than 130/80 is actually more beneficial than targeting less than 140/80. What I say about this, though, is some people are different. I'd say if we had the same measuring tape for everybody, we know that this comes in with mistakes, right? Like, by example, somebody who is morbidly obese, the pressure cuff doesn't fit them well.
Absolutely.
Every time they will measure their blood pressure, it can be a little bit higher because it's too tight on them, right? The opposite, a very skinny person, that even the pediatric one is going to be small, or it's going to be too big for them, their blood pressure can be falsely low. Right, so just be aware of normal variants, and people may tolerate higher blood pressure than others, just naturally. Like, we know that the African American blood pressure is slightly higher than white, and Asians are somewhere in between. Indians are having high blood pressure slightly. So just be aware of these variability and individual parameters, and make sure that the patients are aware of what are the goals. Have a log. I tell patients that you need to measure your blood pressure in different times of the day, but only once a day while you are adjusting the medication. So Sunday before breakfast, Monday before lunch, Tuesday before dinner, and just keep writing them down, and write anything unusual. Like, this is a bad salt day. This is was out the whole time outside in the sun and dehydrated and stuff. I took my medications like 2 hours late that day. So write some notes while you are adjusting it. And if you reach to the plateau phase with blood pressure and you're in good medications, just push it to once a week, and random times as well, once a month probably, and that's for blood pressure. Diabetes, you will know more than me, but I would say I tell people less than 7 goal A1C.
Absolutely.
But there are some suggestions of less than 6.5, at least when I reviewed the literature a few years ago about this. But it's up to the primary care physician to make determination if it's more strict than less than 7, which less than 7 is very hard for some patients.
It is. You're 100% right.
Yeah. And the last favorite is obesity, right? So we are, unfortunately, an obese town, an obese state, and United States is the obese country. So we need to really do more aggressive measures with this. There are many medications now for obesity that people are entertaining. Semaglutide is one of the big ones, but obesity, I'd say it's a habit rather than a medication. So it's you are achieved that weight by certain habits. So the best way to do it is just do different habits to get rid of.
Yeah, that's you hit on literally every single piece that I was going to kind of ask you to talk about. You mentioned the semaglutide. That is one of our favorites in the family medicine realm right now. It's incredibly difficult to get it covered. Hopefully, our patient has that underlying diagnosis of diabetes, and we can use that to help control their hemoglobin A1C, maybe get some weight reduction with it as well, which hopefully helps some blood pressure. issues. So whenever you talked about dietary things, what are you recommending your patients?
So I try to, so the best way to control diet is actually to have a dietitian talk to you about what do you like, because I can tell you certain things that eat vegetables. But if somebody hates vegetables, they will keep like punishing themselves. Why I'm eating this broccoli? I really don't like my greens. I enjoy other things. So,
Absolutely.
I think individualized care is the way to go. A dietitian that specializes in prevention would be the way to go. The goal from diet is not just to lose weight, in my opinion. So the goal from diet, anything that you put in your mouth, you have control over it, right? So anything that you put in your mouth may make you healthier or may make you sicker. That's only one of these two. There is no third option. So you are going to put fibers, enough water, enough hydration, enough vitamins, enough like grains, like whole grains, enough meat, enough like animal protein, plant proteins, etc. You'll be healthy. You're going to put too much of any of these, like even water, right? So SIADH, right? So inappropriate drinking. So anything in excess will put you in danger. So that's why it's a binary system in my mind. I start by telling patients, what are your bad habits? So patients know their bad habits. Me and you, if we assume, right, I can assume that somebody is a smoker, but it's actually may not be a smoker, it's just, right? So, but that's why you would know the patient. The patients would know themselves. So I would ask them, what are your bad habits? So most of the time they answer like knowledgeably, I am struggling with like midnight snacks. Like I eat a lot of sugars at midnight.
Same.
Or somebody would say, I have one meal a day, doc, but that's it. So I don't eat anything during the day. I just eat one meal and go to sleep. And this is my bad habit. So everybody knows their bad habits. And then start to navigate. Again, primary care physician, family practitioners are the best in doing this because they have been doing this very long time. They are actually more accustomed to questions and answer them more appropriately. But I can tell you what I do in my clinic is like deal with the bad habits individually. Like, don't fight them all at once. Take baby steps. So the key to success in changing habits is have a baby step, do it for at least 30 days. So studies showed us that doing one thing for 30 days will make it a habit. If you interrupted it in between, you have to restart the clock. So by example, midnight snacks and hypertension, diabetes, obesity, blah, blah, blah. I tell him just fight one habit, avoid midnight snack or decrease, cut it in half. Eat it, but cut it in half for 30 days in a row. And that's the only habit that you're going to fight and move on. Next time he comes and see me, okay, so what are you successful at now? Okay, good. So now fight the cigarettes, decrease from 20 to 10 or do this, do that. There is no diet that showed mortality benefit except Mediterranean diet, and this was for heart failure, cardiovascular diseases. So Mediterranean diet decreased the cardiovascular diseases. Mediterranean diet is composed of enough seafood, at least once or twice a week, and high vegetables and olive oil, and significant amount of olive oil. Again, some people don't like that, which is totally fine, but I'd say that's the only one that showed decrease in cardiovascular diseases. All of the other diets are there, right? So they are all, I just tell the patient something else as well. Anytime you are on a diet, you know automatically that this is not going to be sustainable. This is not lifelong.
That's good. That's good advice.
So just be aware if Atkins diet, low carb diet, high blah, 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 all of these are non-sustainable. The only thing that makes them sustainable, if you start from the beginning, slow, like piece by piece, not changing the diet all of a sudden, like in a Monday morning, this is, you know that this is not going to happen, right? So change what you like, continue to do what you like, and then piece by piece, remove the bad habits, add some good habits. Like some people don't eat whole grains. Some people don't eat fresh like vegetables or fruits, so they lack certain vitamins. Some people don't eat like enough protein, right? And we have seen like you know that your muscle mass starts to go down after your 40s, and if you don't have enough protein and don't have enough exercise, this may hurt you. Diet is a big area that with many advices and science out there. I'd say make it individualized as much as possible. Just fight the bad habits first, add the good habits slowly, step by step is the way to go.
Yeah, that's really practical advice. And from what I'm hearing, it's a lot of the same things that we are reiterating in the clinic, which is very reassuring. Get the low-hanging fruits, individualize it for the patient, and something that's sustainable. So you talked about diagnosis of heart failure being a clinical diagnosis. We walked through management in terms of diuresis. We talked about the 4 pillars in terms of beta blockers, ARNI, mineralocorticoid receptor antagonists, and the SGLT2s. Then you even went over the risk factor reduction, and we talked about dietary. So I just wanted to thank you for really helping kind of navigate us through heart failure. It sounds like it's a multidisciplinary team from what I'm hearing. So thank you for that. With this, we will be taking our first break.
Thank you for having me, and thank you for giving me the chance.
Cool. That was our first one.
Okay. So
are you running close on time?
It's okay. So I still have.
Hey, that was phenomenal.
Yeah,
you
you're doing excellent as well.
You think so?
You're a good host.
I appreciate that. I'm trying to draw it out of you.
You can do this as a second job.
Yeah, I appreciate that. That's
your backup plan? Okay.
We'll
like
talk about
as much details?
No.
Okay.
Not nearly as much.
Yeah, AFib is a very common one. I tell people actually, and like who rotate with us, there are 3 diagnoses you have to be aware of, no matter what subspecialty do you do. It's heart failure, AFib, acute coronary syndrome.
Absolutely.
These are the 3 ones that you have to. There is no choice because you are going to see them no matter what you do.
We'll talk about CHADS-2-VASc in this one. We'll talk about rate versus rhythm control. And then we'll talk about warfarin versus DOAC. And like, what do you do whenever you've got an elderly patient and they're a fall risk? You can talk about like the Hasbled score versus you take it whichever way you want. We don't even have to get into that. I'll ask.
These are all good common questions,
Yeah.
and this is to be honest, many of the time you guys make the decision.
Yes, I agree.
Like many of the time, it's not like if there is like I have seen many patients who come to me like 20 years of AFib, primary care is managing, and we
you're like, okay, sounds good.
Whatever he's doing, continue to do.
Continue to do it.
Yeah.
Jason, do I need to welcome back or okay? Welcome back to Health Matters here with Dr. Ahmad Elashery. He just did a beautiful presentation on heart failure, and we're going to jump into our next clinical vignette, if that's all right with you, Dr. Elashery.
Of course.
So next, we have Mr. Carter, another gentleman that's well known to the service. He is a 68-year-old male with a past medical history of hypertension and hyperlipidemia. He's presenting today to the clinic with complaints of intermittent palpitations over the past month. He describes episodes of racing heart lasting 15 to 30 minutes, often occurring at rest. These episodes are accompanied by mild fatigue and occasional lightheadedness. He denies chest pain or syncope. Current medications include amlodipine 10 milligrams, atorvastatin 20 milligrams, and aspirin 81 milligrams. Social history includes 20-pack year history of smoking, 2 to 3 alcoholic beverages per week, and he's a retired construction worker. Vitals reveal a blood pressure of 138/86, a heart rate noted to be 110, irregularly irregular, respiratory rate of 16, and 98% oxygen saturation. Physical exam is significant for irregular rate and irregular rhythm without murmurs, no JVD or peripheral edema. His lungs are clear to auscultation. Neurological exam reveals no focal neurological deficits. You review his previous echocardiogram and note left atrial enlargement with normal left ventricular ejection fraction of 60%. Labs reveal a normal TSH, BNP with normal electrolytes, and a serum creatinine of 1.1. BNP was obtained and was 85. Because of his irregular rate and irregular rhythm, you obtain an EKG. EKG is consistent with EKG reveals atrial fibrillation with rapid ventricular response, heart rate of 110, no ST segment changes. So you've got this gentleman, Dr. Elashery, and he's presenting with what seems like new onset AFib. In terms of diagnosing this man with paroxysmal persistent. What are you thinking about in terms of AFib for him?
So the first time, I assume this patient is in the clinic or in the hospital?
This guy's in the clinic, we'll say.
Clinic, okay. So yeah, clinic is slightly different than the hospital, but what I would say is most of these patients, and this is against what we do, unfortunately, most of these patients can be managed in outpatient settings. So if somebody is not significantly symptomatic from AFib, running numbers in the 110s, 120s, this can be managed in an outpatient setting, similar to our heart failure patient that's low risk, and just see them every few weeks to up-titrate medications or have a phone call if the patient is well educated. So back to your question, persistent paroxysmal versus permanent. So and the acute setting is hard to tell, right? Because time is not in your advantage or on your side at this time. So you have to wait and see. But if the atrial fibrillation improved by itself or converted to normal sinus rhythm by itself, right? Or with a medication like metoprolol, this we call paroxysmal. If it persisted longer than a week, and a week is controversial as well, but if it persisted longer than certain time, that's probably 3 days to a week or so, and required a rhythm control strategy like a cardioversion or shock or cardioversion that's electric or chemical, or ablation, that's when we call it persistent. If no matter what you do did not help the AFib, right, and patient remained in AFib, this is permanent. And people use sometimes the time of a year. So if AFib lasted for longer than a year, that's when it's permanent. You should stop trying and just keep the patient in AFib and just do rate control if needed. Diagnosis is easy, straightforward. It's EKG diagnosis. I can tell you that many smartwatches now and many monitors that are actually in Amazon as cheap as $30 or $40 that you can get can tell you if you're in AFib or not. So AFib has been more diagnosed now than before. AFib is one of, to reiterate what I said earlier, so 3 diagnoses that everybody has to be aware of about the heart failure, AFib, and acute coronary syndrome, because you're going to see them no matter what.
Bread and butter.
Exactly.
Absolutely.
AFib is one of the very common diagnoses. It's the most common abnormal rhythm that we have. Risk factors are more or less the same as heart failure risk factors. It's a little bit comes in a younger age sometimes now with avid athletes. We have been seeing it more often. It has genetic components as well. And it's the good thing about it, it's easy diagnosis. So once you see it in EKG, that's it. So typically it's hard to mistake it with something else.
Yeah, you mentioned earlier, we talked a little bit briefly about rate versus rhythm control. What is cardiology's approach to that component?
So I would say the easy answer is everybody is deserves a chance of rhythm control strategy, no matter how old they are. That's in my opinion. Guidelines tells you is rhythm control should be tried in people who are symptomatic. Okay, so these are the 2 important information. I'd say everybody, and I think most of my colleagues would agree that anybody at any age presenting with AFib deserves at least 1 trial of pushing them back to normal sinus rhythm. Guidelines tells you should be guided by symptoms primarily. My main thing about symptoms are, as you know, symptoms sometimes very hard to tease out, and sometimes it's a matter of individual perception of things. Like we have many patients who presents with acute coronary syndrome, like STEMI, and his symptoms can be neck pain or neck discomfort.
Absolutely.
Right? And
non-specific sometimes.
Exactly, and that's why, depending on the symptoms itself, sometimes you don't know if you have the symptoms till you actually convert to normal sinus rhythm, and the patient would tell you, "Aha, now I feel much better.
Yeah.
I didn't realize that I'm feeling bad because of AFib." That's why I say everybody deserves 1 chance. Rhythm control strategy, we have 3 main ways: medications, cardioversion, like electric cardioversions, and ablation. These are the main 3 ones that we do. And I can add like surgical ablation. That's most of the people don't do as a first line now, but if you're going for a surgery for other reasons, sometimes you do it. So which type of these, do you want me to talk about them, or the rhythm control strategy, would you choose which type?
Yeah, sure, absolutely.
So, by example, a young person that has like a college student, by example, that's avid athlete that comes to me with AFib, I tell her or tell him that you need to monitor yourself, because most of the time you are not monitoring yourself, right? Unless you have a smart watch or a monitor. So when you do certain exercises, you try to avoid them, and you can use something like a pill in the pocket, like a flecainide or something.
Absolutely.
Right. So only as needed, you take it. It may help your rhythm right away. If it's somebody with multiple risk factors, like our patients, like hypertension, hyperlipidemia, age, if they have other things like diabetes, coronary artery disease, etc., you know that they are higher risk. So pill in the pocket may not be the way to go, but you may go to something a little bit more chronic or long-term, like medications, ablations, or cardioversion every time it happens. Cardioversions, for me, it has been the go-to, because many people would like just to get it done with. They're asleep, they don't feel it, they wake up feeling better, and it can last for years for some patients. Some of them fail it right away, and some of them fail it within like 6 months or so. Say I flipped back. Ablation versus like cardioversion or versus medication has been a question for electrophysiologists. So some electrophysiologists have more preferences towards like one modality versus the other, and this comes in from studies. So there are data out there that suggests that rhythm control by ablation versus medications, it has like very close results. So that's why it's up to preference of the patients and operator. Now, rate control strategy is a must for everybody, right? You need to control the rate, no matter if you're going to keep them in AFib or not. The rate has to be controlled. Why? When right now, me and you, heart rates are in the 60s to 90s or 100, right? If we are nervous a little bit, it can go higher. If we are running, it's going to go higher. If we play soccer, me and you, it's gonna be higher, especially if we're losing, and if we are dehydrated or it's sunny outside, etc. Right? So that's the normal response. Heart is not used to beat 150 beats per minute while you're sitting down watching TV. So you're not going to feel good, because the diastolic time is going to go down. So the pumping capacity, while it's faster now, the heart rate is faster, the stroke volume actually goes down. So that's when you will have back pressure in your lungs, shortness of breath. You're not going to be able to accommodate. Plus your exertion tolerance is going to be very low, especially if you have other comorbidities as well. So that's why nobody wants to live in 140, 150 beats per minute all of their life. Having said that, some people actually tolerate it well. I had a patient 2 weeks ago who is 70-some, who has HOCM, like hypertrophic obstructive cardiomyopathy.
Oh, wow, yeah.
Who has gradient of, he's a 70-some, like 71, 72 years old, who has gradient across his aortic valve as high as like 50 to 60 millimeter mercury, which is extremely high. And we say anything more than 30 at rest is high, anything more than 50 is high. So he's 50 to 60 with exercise. He runs half marathons, and he runs marathon every year or so, but he runs half marathons like regularly. He bikes, he swims, he's an avid athlete in his age. He has AFib with RVR like in the 130s, 140s for probably over a week. And he would just tell me every time I measure my blood pressure for the last week, my heart rate is in 140s. And I'm feeling okay, but anytime I start to run, I feel bad. So I don't run as like a half marathon. I just run a couple of miles and go home. I tell him, oh my God, like you're like you started already like with 140. So I wonder what's your heart rate when you run? Like it's 160s, 170s,
it has
and
to
this.
Be, yeah.
Yeah. But he's tolerating it significantly well compared to other people. And that's why I'm saying this is a rate control strategy. While guidelines tells us the heart rate goal should be less than 110, and this is everything during even like minor activities, not just sitting down, but 110 overall, the average overall. That's your goal. Some people may tolerate a little bit higher with no significant symptoms, and that's when you should individualize the medications a little bit. Because I gave this patient like metoprolol, and he feels horrible in metoprolol. So I told him we need to shock you, like a shock or ablation, like we can't wait longer. That's when I say rate control guidelines is less than 110 for all the patients, and this is the average heart rate, not just during exercise or not at rest. This is the average heart rate. There are studies that looked at conservative versus liberal heart rate control, like less than 80 versus less than 110, and there was no significant difference in symptoms or outcomes, so that's why less than 110 is our goal now.
That makes sense. You did a great, wonderful job just explaining like paroxysmal versus persistent and permanent, and then kind of individualizing your therapy based on the patient that you're seeing directly in front of you. One of the important pieces that we come across, and you guys alike, is anticoagulation. Who are you considering anticoagulation in?
So guidelines has changed slightly about this, but recent guidelines told us that we use CHA2DS2-VASc score to make a decision. More than 2 for men and more than 3 for women is considered a requirement for anticoagulation. And this all interprets a percentage of stroke risk yearly. By example, if somebody comes in with CHA2DS2-VASc score of like 3, so this probably, I can't remember on top of my head, but probably 6% chance of having a stroke in the next year. So this is not an additive risk. This doesn't mean that in 2 years it's going to be 12%. So the clock restarts every year, right? It's 6% still every year. So, and anything more than 1 to 2% per year, stroke risk qualifies for anticoagulation. This is a conversation that we should have with the patients because, as you alluded to earlier, some people may have high bleeding risk or absolute contraindication to anticoagulation. So the HAS-BLED score has to be in consideration as well, like frequent falls, prior history of severe GI bleed, prior history of intracranial bleed, like a demented patient who doesn't have like good care at home. So you should just avoid anticoagulation in certain patient population, and you should have this conversation with the patients, telling them this just decreases your risk of stroke, does not eliminate the risk of stroke. We have another way of anticoagulation now that's not medication, right? That's equipment. We are very handsy now, cardiologists are, compared to before, so we are doing more procedures, and we have left atrial appendage closure devices that are in the market now for over like 6-7 years, and they have been used and utilized appropriately in our practice. And these are for patients who cannot tolerate anticoagulation. They should be considered for these left atrial appendage closure devices.
Absolutely. And in regards to anticoagulation itself, does cardiology have a favorite in terms of like a DOAC versus Coumadin, or is there a time when this matters?
Yeah, very strong so. So we don't like warfarin anymore.
Absolutely. We
don't have anything specific for DOAC versus the other. We know that DOACs work better. There is not a lot of data to suggest, like, or head-to-head trials to suggest that one of the DOAC is better, and only of one. But again, it's not like any DOAC would be better than warfarin. Warfarin studies showed that the patients are anticoagulated only 2/3 of the time. Like 1/3 of the time, they are either hypercoagulated or hypocoagulated. So it's like the INR is above or below the range that we want it to be. Warfarin is still the go-to for mechanical valves in the heart, but for AFib matter, it's just DOAC is the go-to now, and we try to switch everybody back to DOAC who are on warfarin.
Well, that makes sense. So we talked about a lot of the key pieces today in regards to atrial fibrillation in terms of like classifying it between paroxysmal, persistent, permanent. Talked about rate versus rhythm control and that important piece of anticoagulation. And again, every patient is individualized. Some patients may be at higher bleeding risk, and we should consider the Watchman or the left atrial appendage closure. And you talked about risk factors of congestive heart failure also being very similar to those with atrial fibrillation. So with that, Dr. Elashery, I just wanted to thank you for coming in today. I wanted to ask you a few follow-up questions. If you're going to give patients or not necessarily patients, but if you're going to give residents or other physicians a few take-home points for heart failure, what do you want them to leave with knowing today?
Heart failure is very common. Mortality is still 50% within 5 years, no matter what's your EF. And it's one of the biggest burden that we have in cardiology. That is not, it's too big of a monster that cardiologists, primary care, all individuals in healthcare has to deal with and to fight together and be on the same stand, be familiar with diagnosis, treatment options, and the most important thing is tell the patient the diagnosis and tell them what to expect, because that's the key. If you told the patients that 50% of them die within 5 years, this is a wake-up call.
Absolutely.
Right, and once you deal with it that serious, I think things will be better. Primary care physicians are doing an excellent job around, and we need more of you guys, and we can't do it without you, and we appreciate all what you do.
We appreciate you. And last question, when you're not reading echoes, what can we find you doing outside of work?
I have 3 little ones and a wife, so I try to spend time with them. I like to play sports, so I play, majority of the time now, we play soccer together, me and you, and that is
I hear you're one of the best midfielders in the Kanawha Valley. Is that true?
I would stay away from from big names, but I play soccer, I play tennis, I play racquetball.
So you're getting that 150 minutes of recommended time.
That's correct. And sometimes we are bad in certain weeks, which is fine. It just makes us human beings. But as long as we keep pushing and we keep trying to move to the right direction, I think that's the key.
Yeah. So I'd just like to extend, again, a big thank you, Dr. Elashery, for taking time out of your busy schedule to come and discuss these important issues that, we're always seeing. As always, I hope this episode helps you feel more equipped in your practice to manage these complex cases and to know when to collaborate with specialists to get the best care for your patients. Thank you for tuning in, and we'll see you next time on Health Matters, where we continue exploring the intersection of primary care and specialty medicine. Until then, thank you for joining me on this journey toward better health.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Shay Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.